Alcohol dependence or alcoholism is a significant global healthcare concern. In the United States alone, estimates suggest that over 8 million adults suffer from alcohol dependence. Excessive alcohol use can damage many major organs, especially the brain. Alcohol dependence is a chronic brain disease associated with the dysregulation of several different neurotransmitter systems. In healthy individuals, these neurotransmitter systems are involved in a variety of natural pleasurable processes, such as reward and euphoria. Normal activities that produce these feelings include eating and sex. Such activities stimulate regions within the mesolimbic system of the brain, including the ventral tegmental area, or VTA. Activation of the VTA triggers the release of dopamine in the nucleus accumbens, which in turn produces feelings of pleasure and motivates the individual to repeat the experience. Many different receptor types are involved in regulating our reward pathways. This includes the mu-opioid receptor, which is found throughout the brain, including on neurons within the VTA. These receptors are activated by endogenous opioids such as beta-endorphin. Beta-endorphin binds to and activates mu-opioid receptors. This interaction induces a signal which travels along the axon, ultimately resulting in the activation of dopaminergic neurons. Here, at the dopaminergic neuron, the signal stimulates the fusion of dopamine-containing vesicles with the presynaptic membrane. This event releases dopamine into the synapse. Once released, the dopamine molecules traverse the synaptic cleft, binding to dopamine receptors found on the postsynaptic membrane. In doing so, they activate a series of neurological processes that create feelings of pleasure and euphoria. Repeated exposure of pleasure and euphoria or reward result in a learning process called reinforcement. Memories are formed that connect these episodes with their causes, which are known as cues. Alcohol dependence is associated with changes to a variety of different neurological systems, including the mesolimbic dopamine reward pathway. When an individual consumes alcohol, the alcohol enters the brain, exposing the nerves to alcohol, stimulating the release of beta-endorphin above normal levels. Beta-endorphin is released in both the VTA and the nucleus accumbens region of the brain, stimulating the dopamine reward pathway and producing the feelings of pleasure or reward associated with alcohol consumption. Elevated levels of beta-endorphin increase the activation of mu-opioid receptors. Activation stimulates the release of dopamine in the nucleus accumbens, which is thought to promote acute feelings of pleasure and reward, and over time, reinforcement to repeat the experience. The user experiences the subjective feelings of pleasure and euphoria associated with alcohol consumption. However, chronic exposure to alcohol produces tolerance, meaning that alcohol has a less pleasurable effect, or a person needs greater amounts of alcohol to produce the same effect previously experienced. With chronic alcohol dependence, the brain changes over time, increasing its activation with stimulatory neurotransmitters such as norepinephrine in an attempt to counterbalance alcohol sedation. Upon discontinuing alcohol, stimulants such as norepinephrine are now unopposed by alcohol, which might contribute to the symptoms of withdrawal. Common withdrawal symptoms include an increased heart rate, agitation, sweats and tremors, as well as anxiety and dysphoria, any of which may lead to a return to alcohol in an attempt to prevent withdrawal symptoms. Sometimes alcohol withdrawal symptoms can become life-threatening due to seizures and dehydration. Because alcohol is toxic to brain cells, excessive alcohol exposure over a long period of time can lead to neurodegeneration in multiple regions of the brain. Imaging studies have demonstrated substantial decreases in brain volume and function in alcoholic patients. Please see important safety information throughout and at the end of this video. Also, please see Vivitrol prescribing information and medication guide. Vivitrol, naltrexone for extended release injectable suspension, is indicated for treatment of alcohol dependence in patients who are able to abstain from alcohol in an outpatient setting. Patients should not be actively drinking at the time of initial Vivitrol administration. Vivitrol should be part of a comprehensive management program that includes psychosocial support. Vivitrol naltrexone for extended-release injectable suspension is contraindicated in patients receiving opioid analgesics, patients with current physiologic opioid dependence, patients in acute opioid withdrawal, and patients who have failed the naloxone challenge test or have a positive urine screen for opioids. Vivitrol is also contraindicated in patients who have exhibited hypersensitivity to naltrexone, polylactide coglycolide, PLG, carboxymethylcellulose, or any other components of the diluent. Alcohol consumption exposes the nerves to alcohol, which stimulates the release of beta-endorphin, triggering the dopamine reward pathway. Naltrexone, the active ingredient within Vivitrol, binds with highest affinity to mu-opioid receptors, allowing it to compete with opioids for binding. Although the mechanism of action is not completely understood, preclinical data suggests that Vivitrol produces a blockade that may prevent the increased dopamine release responsible for alcohol's pleasurable reinforcing effects. Because Vivitrol blocks the effect of exogenous opioids for approximately 28 days after administration, patients are likely to have a reduced tolerance to opioids after opioid detoxification. Patients are vulnerable to potentially fatal overdose at the end of a dosing interval, after missing a dose, or after discontinuing Vivitrol treatment. Any attempt by a patient to overcome the blockade produced by Vivitrol by taking opioids is very dangerous and may lead to fatal overdose. Patients should be told of the serious consequences of trying to overcome the opioid blockade. The brain's reward system can be stimulated by many different neuropathways. Mu-opioid receptors are involved in regulating the reward pathway, and naltrexone is thought to selectively inhibit the pleasure associated with alcohol consumption. Because Vivitrol competes at mu-opioid receptors and is an opioid antagonist, it will precipitate withdrawal in opioid-using patients. Opioid-dependent and opioid-using patients, including those being treated for alcohol dependence, should be opioid-free before starting Vivitrol treatment and should notify healthcare providers of any recent opioid use. An opioid-free duration of a minimum of 7 to 10 days is recommended for patients to avoid precipitation of opioid withdrawal that may be severe enough to require hospitalization. The neurobiological mechanisms responsible for the reduction in alcohol consumption observed in alcohol-dependent patients treated with naltrexone are not entirely understood. However, involvement of the endogenous opioid system is suggested by preclinical data. Vivitrol is believed to reduce alcohol-induced dopamine release in the nucleus accumbens. Since the release of dopamine mediates reward, Vivitrol is thought to block the subjective effects associated with alcohol consumption, such as pleasure and euphoria. Cases of hepatitis and clinically significant liver dysfunction were observed in association with Vivitrol treatment during the clinical development program and in the post-marketing period. Discontinue use of Vivitrol in the event of symptoms or signs of acute hepatitis. Vivitrol with microsphere technology delivers naltrexone continuously over the approved 1-month dosing interval. Naltrexone, the active ingredient in Vivitrol, is embedded on and throughout these microspheres. The microspheres are biodegradable polymers composed of polylactide coglycolide, a complex sugar designed to gradually release naltrexone in therapeutic concentrations over a 1-month period. After administration, water absorption causes the Vivitrol microspheres to swell and slowly release small amounts of naltrexone at or near their surface. Vivitrol injections may be followed by pain, tenderness, bruising, or pruritus. However, in some cases, injection site reactions may be very severe and may require surgical intervention. Over time, the polymers degrade and break down, releasing naltrexone over the 1-month period. The polylactide coglycolide polymer breaks down to its monomer, which is then metabolized by the body and eliminated as carbon dioxide and water. When reversal of Vivitrol blockade is required for pain management in an emergency situation in patients receiving Vivitrol, suggestions for pain management include regional analgesia or use of non-opioid analgesics. Monitor patients for the development of depression or suicidal thinking. While the mechanism of action is not completely understood, the evidence suggests that Vivitrol's month-long blockade prevents alcohol-induced release of dopamine, responsible for alcohol's pleasurable reinforcing effects. Vivitrol should be part of a comprehensive management program that includes psychosocial support. Now we will discuss some important safety information about Vivitrol. For Vivitrol, naltrexone for extended release injectable suspension, 380 mg per vial. Indications. Vivitrol is indicated for treatment of alcohol dependence in patients who are able to abstain from alcohol in an outpatient setting. Patients should not be actively drinking at the time of initial Vivitrol administration. Prevention of relapse to opioid dependence following opioid detoxification. Vivitrol should be part of a comprehensive management program that includes psychosocial support. Contraindications. Vivitrol is contraindicated in patients receiving opioid analgesics with current physiologic opioid dependence, in acute opioid withdrawal, who have failed the naloxone challenge test or have a positive urine screen for opioids, who have exhibited hypersensitivity to naltrexone, polylactide coglycolide, PLG, carboxymethylcellulose, or any other components of the diluent. Warnings and precautions. Vulnerability to opioid overdose. Because Vivitrol blocks the effects of exogenous opioids for approximately 28 days after administration, patients are likely to have a reduced tolerance to opioids after opioid detoxification. As the blockade dissipates, use of previously tolerated doses of opioids could result in potentially life-threatening opioid intoxication, respiratory compromise or arrest, circulatory collapse, etc. Cases of opioid overdose with fatal outcomes have been reported in patients who used opioids at the end of a dosing interval, after missing a scheduled dose, or after discontinuing treatment. Patients and caregivers should be told of this increased sensitivity to opioids and the risk of overdose. Any attempt by a patient to overcome the Vivitrol blockade by taking opioids may lead to fatal overdose. Patients should be told of the serious consequences of trying to overcome the opioid blockade. Injection site reactions. Vivitrol injections may be followed by pain, tenderness, induration, swelling, erythema, bruising, or pruritus. However, in some cases, injection site reactions may be very severe. Injection site reactions not improving may require prompt medical attention, including in some cases surgical intervention. Inadvertent subcutaneous adipose layer injection of Vivitrol may increase the likelihood of severe injection site reactions. Select proper needle size for patient body habitus and use only the needles provided in the carton. Patients should be informed that any concerning injection site reactions should be brought to the attention of their healthcare provider. Precipitation of opioid withdrawal. Withdrawal precipitated by administration of Vivitrol may be severe. Some cases of withdrawal symptoms have been severe enough to require hospitalization and management in the ICU. To prevent precipitated withdrawal, patients, including those being treated for alcohol dependence, should be opioid-free, including tramadol, for a minimum of 7 to 10 days before starting Vivitrol. Patients transitioning from buprenorphine or methadone may be vulnerable to precipitated withdrawal for as long as 2 weeks. Patients should be made aware of the risk associated with precipitated withdrawal and be encouraged to give an accurate account of last opioid use. Hepatotoxicity. Cases of hepatitis and clinically significant liver dysfunction have been observed in association with Vivitrol. Warn patients of the risk of hepatic injury, advise them to seek help if experiencing symptoms of acute hepatitis. Discontinue use of Vivitrol in patients who exhibit acute hepatitis symptoms. Depression and suicidality. Alcohol and opioid-dependent patients taking Vivitrol should be monitored for depression or suicidal thoughts. Alert families and caregivers to monitor and report the emergence of symptoms of depression or suicidality. When reversal of Vivitrol blockade is required for pain management. For Vivitrol patients in emergency situations, suggestions for pain management include regional analgesia or use of non-opioid analgesics. If opioid therapy is required to reverse the Vivitrol blockade, patients should be closely monitored by trained personnel in a setting staffed and equipped for CPR. Eosinophilic pneumonia. Cases of eosinophilic pneumonia requiring hospitalization have been reported. Warn patients of the risk of eosinophilic pneumonia and to seek medical attention if they develop symptoms of pneumonia. Hypersensitivity reactions. patients should be warned of the risk of hypersensitivity reactions, including anaphylaxis. Intramuscular injections. As with any intramuscular injection, Vivitrol should be administered with caution to patients with thrombocytopenia or any coagulation disorder. Adverse reactions. Serious adverse reactions that may be associated with Vivitrol therapy in clinical use include severe injection site reactions, eosinophilic pneumonia, serious allergic reactions, unintended precipitation of opioid withdrawal, accidental opioid overdose, and depression and suicidality. The adverse events seen most frequently in association with Vivitrol therapy for alcohol dependence include nausea, vomiting, injection site reactions, including induration, pruritus, nodules and swelling, muscle cramps, dizziness or syncope, somnolence or sedation, anorexia, decreased appetite or other appetite disorders. The adverse events seen most frequently in association with Vivitrol in opioid-dependent patients also include hepatic enzyme abnormalities, injection site pain, nasopharyngitis, insomnia and toothache.